now we are recording. So the left scapula, Dr. Farouk, perfect. Thank you, Dr. Abab. you catch under this at the good time. So now this is the high uptake in the scapula. Yes. And if I show you also down, just yeah. So now maybe you can see that there is also left iliac bone. So you have to look in the CT now and try to see what happened here. Is it a tumor or perfect? So this is fractures, multiple fractures. Where the fracture? In the ribs and in the left scapula and in the, yes, iliac bones, yeah, acetabulum, yes. So this is polytrauma. So sometimes the trauma also have high uptake, okay, in the ribs. So when you find high uptake in the ribs, don't go and just rush to say it is metastasis, or in the scapula and say this pathological fracture. No, it can be, okay, agree? Agree, okay. So what about this one? Again, what? When you find high uptake in the ribs, you rush and say that it, yeah, it can be, yes, it can be fractures. So this is a fracture, especially when you have the CT and you can see it is clearly that is trauma, okay? So what do you think about this one? Multiple levels, increase the uptake in the bone, along the bone, right? Yes, and there is some areas of collapse in the vertebral bodies, yes. You can see it in the CT, nice. So this is, yeah, nice. So this is degenerative. So sometimes also the degenerative spine can have high uptake. You can see the vacuum. Yes, nice. So not just the tumors, not just the metastasis can have high uptake. Again, you can see this, osteophytes, and along the osteophyte there is very high uptake, okay? I think maybe, okay, you can take because we don't record anything, so we can at least. So what about this one? Yes. What do you think about this? Yeah, it is inflammatory. Yeah, there is some increased uptake in the right side, as you see here, and there is what? Increased uptake along this joint, which is the sterno, yeah, clavicular joint. So when you find the sternoclavicular joint with high uptake, so maybe this one is inflammatory. Perfect. Inflammatory osteoarthropathy, yes. So sometimes also the inflammatory conditions can have high uptake. So what about this one? Yes. Lymphadenopathy in the CT. And in the PET CT, what do you see? This lymphadenopathy include which groups? Mediastinum, do you agree? Mediastinum? Yeah? Mediastinal groups, okay. So you have here, yes, multiple mediastinal groups. And if you look in the MEB image, you can see that there is mediastinal, supradiaphragmatic, and also there is infradiaphragmatic. So, Ala, nice, you mentioned, and also there is inguinal and there is axillary, perfect. So you have multiple, and if you go up, you can see also that there is something like maybe some uptake, high uptake in the parotid and the salivary glands. So what is your recommendation? You will think about, Ala said lymphoma, okay. If it is not lymphoma, what do you think? Yes, perfect, sarcoidosis. And what else missing? in your differential and can have high uptake, TB. So again, the BCT is not specific to say it is lymphoma. You should have something like biopsy or whatever. But if you you have just these images without any history, without any biopsy, so you will put all differential, not just lymphoma. Yes, lymphoma have high uptake, but also the sarcoidosis, TB, the METs. So this one was sarcoidosis. So okay, do everyone agree? Okay, let's have a look in this. So by CT, what do you think about? And what about the bed CT? Try to localize first the perfect reconstruction to the sagittal,
Right lung,
you know the anatomy. So where is it? This one?
Mass with increased uptake.
Yes, perfect. So where is it? It is middle or upper loop? Is it upper or middle?
Middle loop, I think.
I can see that there is line here. If it is this line, and I think this the minor fissure. So I think maybe it's upper, maybe. I'm not sure, but I think if it is this line, the fissure, okay, maybe upper. But okay, let's say that because it's just one image, so we are not sure. So what do you think about here? If have high uptake, what is your differential? Especially when you see this histological image. If someone is experienced in histology, what it could be? Yeah, and even the explanation, he showed that it is just adjacent to the fissure. So yeah, it is in the right upper. Yeah, as I mentioned, it is in the right upper loop. Okay, so I see granuloma, nice, carcinoma, perfect, pleural, but he said that is not in the fissure, and I agree that is not in the fissure. It is inside the fissure, so it is not pleural. But I agree with Nermin that it will be carcinoma versus granuloma. So this one, it was granuloma, which is pulmonary cryptococcosis. Okay, pulmonary, which is a fungal infection. Okay, so let's have a look in this, and I hope everyone enjoying the BITS-T. It is more colorful than the chest yesterday, so I think everyone maybe like it more. So what do you think about here, this lesion? Where is it, and how you describe it from the CT first? What do you describe from the CT? Okay, Muhammad, anterior aspect, right or left? Are you sure that is right?
Left upper lung loop, anterior segment, cavitary lesion,
okay,
extending to subcutaneous.
So do you agree that there is extension in the, maybe in the pectoralis and after more in the subcutaneous? Okay, so cavitary lesion, you should mention cavitary lesion. Perfect, Ala. So you should mention cavitary lesion, yes. Anterior segment, left upper loop, perfect. Cavitary lesion and have extension to the pectoralis anteriorly until the subcutaneous. So how do you describe it? How do you describe it?
Infection, it's abscess extending to subcutaneous
perfect
tissue of anterior chest wall.
Yes, nice. So you suggest that maybe it's infection. Nice. So it is, maybe if you are more accurate, we can say it, sinus, fistula. What you can say it. Choose one. Choose one. Huh? What you will choose? Nice. TB emphysema, one of the good differentiate. Nice. But how do you describe it? It is sinus, fistula. What you can see it? How you describe it? Huh?
With
fistula, perfect. So the most important, the cavitary lesion, and have continuation outside. So you are talking about like fistulation, right? So now we have fistula, and when you have fistula and this type of things, that you should look about the, yes, look about the infection. So differential will be including infection. This one was what? Actinomycosis. Yes, actinomycosis. Okay. So this one, it was really nice case, and it wasn't infection. Can the tumor make this? Yes, especially post what? Post treatment, especially after radiation or surgery, it can have similar appearance. But sure that you can put infection if it doesn't have any history. Okay. Okay, let's have a look in this one. I'm sorry about the recording, that about maybe 15 minutes from this lecture wasn't recorded, so hopefully we can repeat it maybe later. But okay, what do you think about this? From the CT, how do you describe? Where is it? Okay, so describe it as mass along fissure. So related to the fissure, yes. So the major fissure of the left lung. So lesion or mass which is related to the fissure. Perfect. Have high uptake. So what is your differential? Especially after you see the histopathology. Look in the CT, just the CT, and try to characterize better. So sure that you will put like cancer or tumor as a first possibility. Doc, perfect. So yeah, no, it is not effusion. The effusion will not take uptake. It will just the margin. If it have something in the margin, it will take, but inside it will not. It will be photopenic. Photopenic, yes. So what do you think about this mass, which is high uptake? METs, good differential. What else? Carcinoma we mentioned. What you are missing? Two things you are missing: the fungal and perfect nermine and mesothelioma. Good choice. Thank you, Shayma. Fungal and this case, what was? It was the most important to know. Fungal and lymphoma also good choice. Thank you. Yes, but fungal and what is similar to fungal? It can happen everywhere. TB, perfect nermine. So TB. So this one was with biopsy diagnosed as TB. Yes. Okay. Everyone is happy. Okay. This will resume after 1 minute. Take the. Okay, we just finished this case, which was like lesion, and it is based or located in the fissural or adjacent to the fissure. And from the biopsy, they say that it is pulmonary TB. So not just cancer can take high uptake. Okay. So what about here? As you see, you can see that there is this lesion in the CT. So where is the location? You can imagine that the fissure is here, and this is the major fissure. So this is the lower loop, and this is the middle loop, and this one, it will be the, yes, the upper loop, yes. So if this upper loop, what about this lesion which doesn't look like have high uptake? It have low grade uptake, or maybe, yeah. So as you see, the heart have very high uptake, which is physiological, but this lesion doesn't have high uptake. So what is your suggestion about this? Which is, I agree that it is like pulmonary. Why pulmonary? Because it have acute angle or obtuse angle with the pleura. Is it acute or obtuse? Okay, I show you the answer, but okay. So it is acute or obtuse? Acute. So when acute, it is pulmonary. Yes, pulmonary. It is not pleural. So it is pulmonary lesion, and when it is pulmonary lesion, you will give some differential. Sure that you will put again carcinoma. If you focus in this nature of this lesion, maybe that something that can tell you the answer. Yeah, Shaima. Okay, so this one, if you suspect that there is focus of calcification here and it have some low density inside, so this one, it was hamartoma. So as you see, it doesn't take high uptake, which is typical for hamartoma. But again, in this case, you should put other differential, but one of them sure will be hamartoma, especially when in the PET-CT it doesn't have high uptake, FDG uptake. So this means that is have low metabolism, which is typical for, yeah. Also, you can put infarction if you have history of pulmonary embolism, or you can see something. Yes, thank you. Is good differential. So this one was hamartoma. What about this one? When you characterize, try to characterize from the CT purely without affection by the PET-CT, by the FDG uptake, yes. Then after that, you can reach the diagnosis. This is in the real practice. So this patient have history, very interesting history of something I will tell you later. Then, as you see that he have like opacity here, is it, yeah, pulmonary? I think it is pulmonary. And if it is pulmonary and it have pleural attachment to pleural base, and it show also some pleural thickening. So I agree with you that maybe you can think about round pneumonia, but round pneumonia, if you remember, we have pleural thickening, which is considerable, and you can see this sign with swirling sign, and you have some also vascular swirling and so on. This is not typical for this appearance from the CT. So no, it is not round atelectasis. It is not. It's very just what differential, yes, infarction can be, and the uptake in the FDG, it have low grade uptake. This give you that maybe is not a tumor or metastasis. So you will put just metastasis and tumor as good differential, and you can put also some infection as good differential. But this patient have good history of eosinophilic vasculitis. So this opacity, when they take the biopsy and histopathology, they proved that it is eosinophilic vasculitis. Okay? Okay. They want to show you that, again, with some devices, you can have beside some uptake. So maybe this uptake could be, as Dr. Amr shared with us from a while, that it could be what? When you have high uptake beside the prothesis, you should mention it and say that maybe it is related to what? And you should correlate clinically with the patient. It could be inflammation, perfect. So it can be inflammatory or can be infectious. So correlate with inflammation. So correlate with the clinical data. Yes. So what happened with this patient? As you see that if you will ask about history, you will ask about history of about history of surgery, operation, right? As you see that this patient, he have like this breast, okay, which is look like normal, but the other breast, he underwent something, yes, and also you cannot see the upper limb itself, yes, you can see the continuation of upper limb here, you cannot see. So you have an operation including the upper limb and maybe also part of the breast, and you have this air. So what happened here, this uptake, what it represent, what could represent this uptake? It can represent what? Can be represent infection, yes, or post-operative changes. Nice. So Rabab, infection, or yes, or perfect. Nermeen. Recurrence, if this patient have history of tumor, then if it is very recent, you cannot say that it's recurrence because the tumor, it will take time until it have recurrence. But if it is like much time, for example, he have this operation from 2 years and then have this appearance, then maybe you can think about recurrence. Yeah. So let's shift to this case. Okay, and he have, as you see from the CT, you can see this appearance. So what happened here? We have like describe it, try to describe this appearance. What happened here? This is the MIB view of the bit, just bit MIB view, sorry, the axial bit, and this is the axial CT, and this is the fused image. So bilateral ground glass opacities, corona, one of the good differential maybe. So ground glass opacities, and you can see some reticulation and some interstitial thickening here also. So okay, so pneumonia, one of the good, Nermeen, nice. It will be one of the good differential in this case, even if you have very high uptake like here. So this one, it was pneumonic consolidation, yes. And this patient, he have good history, interesting history, sorry, that he have pneumonectomy. Then this he have chemotherapy treatment, and this chemotherapy treatment result in this consolidation which you have here. So this like a drug related consolidation or drug related pneumonia, yes, post treatment of chemotherapy. Okay, so one of the good differential that you can put, you can ask the patient if you have any treatment with chemotherapy or drugs, then it can show you this similar appearance to many things. Okay, we are about to finish this slides and go to regular chest without any colors. Okay, what do you think about this? I can see that there is something going in the middle loop. You can see here the minor fissure, the major fissure. So this is the lower loop, upper loop, and middle loop. So you have something in the middle loop. I don't think that is cavity. I think that it is like a consolidation, yeah. And how do you describe it? If I told you that this patient have breast cancer, so what is your suggestion? Yeah, what is your suggestion? It can be, okay, can be metastasis, carcinomatosis, but it's not typical appearance for lymphangitis carcinomatosis. It's not typical, so you cannot put it in your top meds, okay? But I am waiting. Yeah, Rabab, perfect. Ala, radiation. So don't forget radiation. Radiation can make this similar appearance, and this patient have post-radiation pneumonitis. So this one, it is post-radiation. So one of the good differential, you put radiation. Sure that finally, this is a chest. You cannot from one image say what is it, but you can correlate with the clinical condition, with the history, with many things. Then you can finally reach diagnosis. But let's have a look in this case. He won't show you that there is something here by this red arrow. So what is this?
Right axillary lymph node.
Perfect. So this is like look like a right axillary lymph node, and I can show you now here what is going on with this very small axillary lymph nodes. Okay, so he won't show you this axillary lymph node, and what happened here?
Mildly increased uptake.
Yeah. So I just, to be honest, I make something like deceiving. Why? Because this patient, yeah, it should be like he take it for lymph node, but it doesn't. As you see in the CT, it have here fat. So this means it is not true lesion. So what other interpretation you can put it? Yeah, if you don't find any CT correlation or any, so it is fat. Yeah, okay, but here the brown fat, we saw it. It was like bilateral symmetrical. By the way, this was in one in the FRCR exams, and he show you this similar picture or image, and he asked like basic question: if this one it have this, and you cannot see in the CT anything, but maybe it was like more obvious. To be honest, this one is not obvious. So go away from any lesions. Try to find another solution. What happened with this patient? What happened with the FDJ? Remember when you have the contrast, and the contrast sometimes have what is called the contrast. Imagine that if it is like a contrast, and sometimes the patient, when he injects the contrast, what happened with this patient? Yeah, extravasation. Perfect. Yes. So this was called extravasation. They like it in some exams to show you that this is very, very basic. To be honest, this one wasn't easy. I can show you the answer now. It wasn't very easy, but when you see in the practice, it's more easier to see it in the 4R, the extravasation or the contamination. But sometimes it have like this, and when it doesn't have any correlation in the CT, then start to think about it. Okay, so let's now shift to our image and see what it could be. This one without color now. So I think this one, it was easy. When you saw it in the X-ray, what you will put? Yeah, and nice. So one of the good differential will put the ventricular aneurysm, and there's some questions in the text about how to differentiate between the true and the pseudo or false aneurysm, right? They like it in the MCQ much, so try to be aware about them. Yeah, I'm waiting for the answers. Yeah, so you are like here a bump in the left heart border. So this is aneurysm. another shape of this aneurysm, as you see, yeah, and already the patient like have operation and so on. In the lateral, they show you again. So be aware of them, especially when you see this pump sign of the left ventricle. So you are talking about aneurysms, okay? In the angio, they have this like very nice picture. Yes, they show you. And in the CT, they like to show you this one. Then how you can differentiate, for example, between this one and other examples, like we mentioned constrictive pericarditis as one of the good examples that have calcification, for example. Yes. So when you find it like a focal and related to just the aneurysm, so this should be like aneurysm. Yes, it is not all the pericardium, not all surrounding the pericardium, so it is not. And also the pericardium thickening is like another helpful diagnostic issue. Okay. And also in the constrictive pericarditis, I will just show you this. It tended to spare the apex, which is the most common site for the aneurysm here. I mean, it doesn't like to be like typical in the apex. They say in the history that it tended to spare the apex, that it can help you to differentiate it from the aneurysm of the heart, okay, of the left ventricle. Okay. Again, in the MRI, okay, so this is what is called ventricular aneurysm. So which one will have like a narrow neck? The false or the true? The false, yes, the pseudo one. So why? Because the issue that the ventricle, what happened with the ventricle, it ruptured, but still the pericardium is intact, right? And what happened? It's like a contained rupture. Then happen organization. So if I show you this one, it will be like true or false. Yeah, contained within the pericardium. So this one, it is true or false. It is the false one, yes. And if I show you this more, it will be more representative. It will be again the false one. So the false ventricular aneurysm. Why is false? As you see, it is like the ventricle rupture. Usually the location in the posterolateral or the diaphragmatic wall, okay? Yes. And it is different from the true one, which is transmural MII, post-transmural MI, and it is like a smooth bulge of the left heart border, okay? And as we saw, it was having maybe some calcification and maybe thrombus in the, at this one, yes, have calcification or have thrombus in MRI. Okay, let's shift to another case and try to put description, then try to find the differential. So metastasis would be nice, good differential, and yeah, so if you just try to see that there is maybe some cavitation in this lesion. So as I mentioned, that bilateral cavitary lesions. So here the differential of bilateral cavitary lesion, they like it in the exam so much. So you will mention Wegener, septic emboli, MITS, cavitating MITS, Wegener, perfect, nice. Septic emboli, infarctions, maybe trauma, TB, fungal, this is the most important, TB and fungal. Okay, so this one was Wegener, which have nodules or maybe sometimes nodule with calcification, and they like it to mention this in the MCQ, and also that you ask about C. ANCA that is positive in 90% of this patient. So this is the differential of the cavitary lesion, which is very important to know. And you already mentioned it, neoplastic, and the most important, the squamous cell, because it is very common to have necrosis. And also TB, fungal, which is the most important. Then after that, you will mention Wegener and the septic emboli. Okay, thank you, Shayma. So I will show you just something like this one. It was the mycobacterium, and they have some cavitation here, squamous cell carcinoma, which have necrosis here, yes. And this one, this patient have history of intravenous drug use, so it will be what? It will be what? Septic, Marihan, perfect. So this one, it was septic emboli. And this one, it is a bit rare. Just to try to describe it, it was papillomatosis, yes. Okay. This one is very important for all exams, especially for the FRCR. They show you that this X-ray, and they want you to just say one answer. Yes. Deep sulcus sign, pneumothorax. Yes, perfect. And it's deep sulcus sign, yes, in supine patient. So perfect. Deep sulcus sign. So you cannot very easily detect the white pleural line as we saw it in many. You can just see the deep sulcus sign, and they say that the air accumulate behind the diaphragm, so you can see sharply define the diaphragm, the hemidiaphragm. Okay. So this one, they like it in the exam to mention, and very important. This called pneumothorax in supine patient with deep sulcus sign. Okay. Sometimes they show you. Okay, let's skip this one. Okay, because it's a bit difficult. But this one, sometimes you want to show you some displaced tubes or lines. I think this one is more obvious that what happened here. Yeah, look in this catheter, which should be in the, should be in the, for example, the superior vena cava. But what happened in this catheter? It go and migrate upward through the jugular vein. Okay, so this one is migrated catheter. So what about this one? They won't show you what? So this patient have like pacemaker, and you see the leads, okay? And what about this line? It go where? Yeah, so why it is wrong location? Why do you think that there is wrong location? What is the other? Perfect intermediate, nice. So this left superior vena cava. So be careful about that. Maybe sometimes you have vascular anomaly in this patient to have left superior vena cava, okay? So let's have a look in this one. And what happened here? In this central line, yes. This central line, what happened? Like a kink, and this kink happened in the level of the subclavian, yes. So this kink happened in the level of the subclavian, okay? So what about this one, which is very common, as they show you the displaced and migrated tubes and line. What do you think about this? Endotracheal tube is displaced and go inside the bronchus intermedius to the right. Perfect. So again, what about this? It should be like a nasogastric tube. So where he put the nasogastric tube? Yeah, he put the naso in the right lower loop bronchus. Perfect. And he make like lung injury. And yes, where he put the nasogastric tube again? This patient, where they put the nasogastric tube? Yeah, you can see what happened here. Okay, so intracranially, yeah, intracranially, something very, yeah, like this. So take care about the like it in the exam and the ADIR, FRCR, all the exams that this malpositioned lines, tube catheters, be aware about them. They like it, and they will show you some lines and some, okay? So, okay, sorry, I will skip this one. Let's have this. Yeah. What happened here? Yeah. So try to describe what is your key. Yeah, the AB window, nice. You remember yesterday we talked about the AB window, AB stripe. So here you have a bulge. So which mediastinum, if you remember, it will be the middle. And if it is the middle, it will be vascular. So try to think about the vascular. So if it is vascular, then now you are going to put good differential. And if I show you this one, so the pathology will be the pulmonary artery. Perfect. The differential, one of the good differential will be the pulmonary artery. So what happened here in the pulmonary artery? Can you describe now? The main one is, yes, enlarged, yes, and the left one is also enlarged, yes. So this is what is called pulmonary stenosis. So pulmonary valvular stenosis can be congenital. You can find dilated main and left pulmonary artery, main and the left pulmonary artery. But the right side is normal, like here. You can find the right side is normal, yes. And no shunt vascularity, so you cannot see any increased pulmonary vascular markings. And yeah, sometimes the right ventricle is mildly dilated, yes. Again, if you remember, we talked about this yesterday. So this one, what happened here in the ascending aorta? It is Yeah, dilated. So this is what's called ascending aorta aneurysm. Yeah. So this is dilated. Yeah. So why the aneurysm? If you want to put some causes of aneurysmal dilatation, ascending aortic aneurysm, what could be the causes for this? Could you put like Marfan, Takayasu, and sure atherosclerosis? Perfect. Ala. Yes, nice. Connective tissue. So they mentioned that the Marfan like the sinotubular junction or the ectasia. Yes. And there is also the syphilis. Okay. Okay. Takayasu like to have aneurysms with stenosis and the atherosclerosis, which is maybe the most common, fusiform plus or minus thrombus. If it is more than 5.5, it is surgery. Okay. So what about this one? Do you see any abnormality?
Right middle lung zone nodule.
Yes, perfect nodular opacity in the right mid-lung zone. So this entity called solitary pulmonary nodule, then you should characterize either is it below 3 centimeter or not, and then you want to know it is benign or not, because your first differential will be metastasis, or if it is benign, you are going others. Okay, then you are going to characterize, and they have this diagrams that help you when you have some calcification inside, then you can characterize. Okay, so if it is central, what it will be? The benign will be benign. Yeah, perfect. Ring laminated, it will be benign. If it is popcorn, it will be benign. And if it is diffuse, it will be benign, including the granulomatous and fungal and so on. So when it will be like not benign, when you have which type of calcification? If you find in the solitary pulmonary nodule, you can think about suspicious criteria. If it is, you like it in the MCQ, banketed, perfect, or eccentric calcification, or no calcification at all. So it will be suspicious. And they like now to do PET CT for characterization and staging of, yes. Again, let's have a look in the CT. So what do you think about what I show you in the PET CT? What it could be? Hamartoma. Why hamartoma? Because you have fat density. So in this case, it will be a benign looking lesion. Yes. And this one, it was hamartoma, but it's one giant and is not typical. And you can see the calcification, but is not typical to be like this giant pulmonary hamartoma. And here the management of the solitary pulmonary nodule, and you can see the characterize the patient low risk and high risk, and including some follow-ups and so on. Okay. So we have like 3 minutes, and we will end today like short session, and inshallah maybe in Wednesday we can continue for this week, inshallah. So what about this one? What do you think? So your first question, where are you? You can see the enhancement. This is arterial phase, and yes, and you can have this aneurysm would have like mural thrombus, yes, and you can see that there is atherosclerotic changes along the descending thoracic aorta, yes. So the most common cause for this will be atherosclerosis, especially when you find the appearance like a bit fusiform appearance, and with thrombus it will be the atherosclerotic type, yes. Okay. If it has rupture in the CT, it can have mediastinal hematoma. You remember the case I showed you from a while. It was in the bed CT. And when you have this appearance, I want you to comment in the pre-contrast, which is maybe here is more important than the post-contrast. Yes, abdominal aortic aneurysm with leaking. So why you mentioned this? Or at least you can say impending rupture. Why you are saying that is impending rupture? Why? Show me if you can the most important sign here.
And interrupted the calcifications.
One of the good signs, the calcification, but if is still intact, there is something very, very important in the non-contrast. Yeah, Ala, what is, okay, you mentioned something, how you describe it. What is this? So hematoma, yes. So hematoma, how? The high crescent, high attenuation crescent in the mural thrombus. So in the pre-contrast, when you find it, this high attenuation crescent, this means that probably is hematoma. And this is like very important impending rupture sign. One of the most important impending rupture signs, okay? And when you inject the contrast, sure that it will give you again impression that it is here. So high attenuation, this impending abdominal aortic rupture. Thank you for today. I hope that everyone enjoy. And again, we talk about Dr. Ahmed, and he passed away today. Allah yarhamu wa yaghfir lahu. I send his presentation, and I hope everyone can share it. And يعني صدقة على روحه.